Alright guys, welcome back. So last video we did respiratory physiology. We talked about some funky stuff from up here, right? We discussed all the lung volumes, we discussed some of the initial equations about dead space and minute ventilation, and then we looked at this graph from UWorld where we talked about where and how alveolar pressures as well as extra-alveolar pressures, how they change, right? As you breathe in, what happens to those two pressures and what happens to the total pressure. Right? And overall, we learned that pulmonary vascular resistance, right, your alveolar blood pressure, is lowest at FRC, right here. And then it increases with increasing lung volume from here onwards. And we talked about all of this in the last video in really good depth because the whole physiology of understanding how this works and why this occurs is actually very important to understand, because if you don't get this stuff right here, then as we go on, there's more curves and more graphs regarding the same physiology, and the rest of it won't really make sense either. So let's take a look one last time. So of course, in the beginning, when you have no air in your lungs, your alveolar blood vessels are really dilated, right? All the blood comes to the alveoli, and at this point where you have no air in your alveoli, you're basically releasing CO2. Now, as you breathe in and more air comes into the alveolar blood vessels become very constricted, right? Pressure increases. Why? Because now air is going into those blood cells, the hemoglobin is picking up oxygen, and then that blood has to be sent away from the alveoli by constricting these vessels so that blood travels out of it and sent to muscles where you need the oxygen, basically, right? And this total pressure was a sum of your extra-alveolar vessel pressure plus your alveolar vessel pressure. And this red stuff here is your alveolar vessel, right? So you can see how it's really low over here. The pressure in alveolar vessels is really low here. After from this point onwards where you're breathing in, alveolar pressure increases and the alveolar blood vessels constrict. Right, so just remember that, and then the extra-alveolar stuff is opposite, but because they're opposites, the total is this parabola over here, the red, right, like a U shape. So at FRC, your pulmonary vascular resistance is at the minimum, and that's something you can get a very straightforward question on, and this is exactly what this UWorld question was testing you on. Now, on the next page, we see a couple more graphs, right, and this stuff tends to be very intimidating to a lot of students. Many people who do end up studying this often just check it out and then they're like, I'm just gonna look at it, read what it says, and move on, rather than actually truly grasp what's happening. Very few people tend to really master what's happening on this page and what's happening in this this graph on the top left especially, right? So most people are able to understand what's happening in this one, and this are the same thing, just different visualizations of it. This is also the same thing, but teaching a different aspect. Here, this graph on the top left is the most important one on this page, and it's something that a lot of students don't tend to understand. So let's just read the graph first and make sure we know what's happening, and then we'll read everything else and take a look at my notes after that. So in this graph, you can see on the left half, the lighter blue shade is inspiration. The darker blue on the right half is expiration, right? So you're breathing air in, and then you're breathing air out, right? So you can just follow the mouse as it's happening, breathing in air, breathing out air. That's it, right? And when you're at the bottom here, that's FRC, functional residual capacity. When you've breathed out everything you basically normally would breathe out, right? Functional residual capacity is this stuff right here, which also encompasses residual volume, right? The air that you do not breathe out. So keep in mind, that's what we're calculating with the 0 here, right? All the way up to 0. So now, what's happening with alveolar pressure and intrapleural pressure as you're breathing in? Well, you can see as you're breathing in, alveolar pressure first becomes more negative to almost -2, then goes back to 0, right? Halfway. So at the halfway point, things change, right? So right here, let me see how thick this is. Let me just make it very thin. So right at this point, somewhere right here, right, you can see how things are affected right there, right? So there's a very straightforward change right here. So halfway through inspiration, you reached a minimum, then came back up in terms of alveolar pressures. And then when you start expiring, right, when you're breathing air out, the alveolar pressure becomes more positive, then becomes 0 again. So you have to remember that. This curve you have to be able to remember, and if anything, you should be able to redraw this also for your cheat sheet or whatever it is you plan to use if you ever have a question on this kind of stuff. As far as intrapleural pressure is concerned, that's more straightforward. As you're breathing in, intrapleural pressure just drops, becomes more negative, right? And then as you're breathing out, it just goes back to normal. But this pressure, the intrapleural pressure, is always negative. Intrapleural pressure should never be positive. Right, so intrapleural pressure, you can see, goes from about -5 to almost -10, then it comes back up to -5. That's it, right? So elastic recoil, FRC, compliance, and hysteresis. These are the main 4 topics that are discussed on this half of the page. So elastic recoil is the tendency for lungs to collapse inward and chest wall to spring outward. And this was discussed heavily when we talked about elastin, way in the beginning of biochemistry. Right, we talked about elastin and its properties and how alpha-1 antitrypsin deficiency can lead to overactivity of elastase, and then you can lose the elastic recoil and you can get emphysema, right? So that stuff is going to come back again. It's going to be very important here. Elastin was also relevant with Marfan syndrome in biochemistry. FRC is when you have inward pull of the lung balancing the outward pull of the chest, and the system pressure is atmospheric, right? So atmospheric pressure, we tend to go with 0, and that's what's happening right here. So at FRC, functional residual capacity, when your lungs are pretty much empty. At FRC, airway and alveolar pressures equal atmospheric pressure, which is denoted to be the 0 point. And intrapleural pressure is negative, right? And you need this to be negative because that prevents your atelectasis, which is basically the blowing up of all your alveoli. If your intrapleural pressure is not negative, your alveoli will collapse. The inward pull of the lung is balanced by the outward pull of the chest wall. System pressure is atmospheric. Pulmonary vascular resistance is at a minimum, right? This is all basically at FRC, and that's what that question we did in yesterday's video was about too, right? This one. When would total pulmonary vascular resistance be the lowest? At FRC. Right, so clearly a very important little topic that you need to know about for step 1. Compliance is the change in lung volume for a change in pressure, and that's expressed as delta V over delta P, change in volume divided by change in pressure, and is inversely proportional to wall stiffness. High compliance means that lungs are easier to fill, right? And emphysema, normal aging are things that you're going to have to worry about later on. Lower compliance means that lungs are harder to fill, and this is related to pulmonary fibrosis, pneumonia, neonatal respiratory distress syndrome, pulmonary edema. And both of these are different cases we're going to be seeing a lot of, right? If you have too much compliance, emphysema, and it's also part of normal aging, so keep that in mind. Normal aging is a very big deal. We saw a lot of questions regarding normal aging with cardiovascular, right? The question would tell you things about some patient's heart, often mentioning lipofuscin as well, and then you just have to pick normal aging because those are just normal things that occur to the heart. With the lung, you also have similar things, and we're going to see that on the next page. I have a table from UWorld that talks about pulmonary function tests in aging. The next thing is your surfactant, right, which we talked about earlier in respiratory embryology. Surfactant's job is to increase compliance and help you breathe. Normal compliance is 0.1 to 0.4 liters per centimeter. And just in case you get a weird question where they tell you those numbers, especially in NBME, you should be ready with that. The last concept that this half of the page talks about is hysteresis, which I've really never seen a question on, but it is a mathematical / physics thing that is not too hard to know. So basically they're telling you in hysteresis that lung inflation is a curve that follows a different curve than the lung deflation curve due to need to overcome surface tension forces during inflation. So basically you can see how here in this graph, right, this graph is showing you the hysteresis, which is shown in green. So when you're breathing in, right, you go from residual volume to TLC, total lung capacity, on the y-axis. On the x-axis, you're basically seeing transpulmonary pressure. So as you breathe in, you're going upwards. As you breathe in, you can see the red line goes in this manner. But when you breathe out, you would expect, normally, without hysteresis, you would expect the line to just come backwards for expiration. It doesn't come backwards. Expiration has its own curve, right? So there's a difference, and that difference is hysteresis. There's a difference between the curves or the path that inspiration takes versus expiration, right? And that's related to the fact that compliance is a big deal. right? And these black lines, which are pretty much derivatives, right? They're lines that are perpendicular at some point of the graph. Those are lines that are showing you the slope at that point. The slope of this graph, which is volume over pressure, is basically compliance, right? This is something you need to be able to figure out. Compliance is measured volume over pressure. So if you have volume over pressure, any slope you look at of a graph like that is always this axis over this axis. So it's compliance. You can see in the beginning and in the end, the compliance is a very almost zero kind of slope, right? So you have low compliance at low lung volumes, and you have low compliance at high lung volumes. Why? Because when you have low lung volume, your lung doesn't need to really comply to anything, so there's low compliance. And then when your lung is full, it cannot comply anymore, so that's also low compliance, right? In both cases, the lung is not going to be changing. But while you're breathing, the lung is changing, right? While you're breathing in air, your lung should be complying, and it's actively going to be expanding as you breathe in. So there's high compliance during inspiration, right? High compliance around the FRC point, which is when you have the lowest pulmonary vascular resistance, right? So highest compliance, lowest pulmonary vascular resistance, all of that stuff basically occurs at FRC. So this is your points of, this is your graph of breathing in. And then when you're breathing out, that's a lot easier in essence, right? You breathe out, it just comes out naturally. Pressures all go back to the way they were, and it takes a different curve, all right? So that's hysteresis. Not the biggest deal on earth. It's just a concept that is worth knowing. I wrote over here that at FRC, the intrapleural pressure is approximately -5 centimeters water pressure, which further decreases during inspiration to almost -10. Right, and that's something that we talked about earlier. On the bottom, I have some information regarding these same graphs. So on the left graph, which is this one, related to the one over here, x-axis is showing increasing pressure, right down here, and the y-axis is showing increasing lung volume, total lung capacity, right, from residual volume all the way to TLC. When airway and alveolar pressures are zero, it is atmospheric pressure, which is depicted by FRC, right, and that's right here. Zero is the point that has the red dot with FRC. At zero, the chest wall's force is described as an outward pull on the lung tissue. So the chest wall has a natural tendency to expand in the anteroposterior direction. The lungs are opposing this, but this opposition is missing in emphysema patients, which is why their lungs can collapse. The lungs have a natural tendency to collapse with an inward pull on the chest wall, which is opposed by the chest wall. If the chest wall did not oppose this, the patient will develop a pneumothorax. Right? This is why when someone has a pneumothorax, you can make a hole in their chest to fix this pressure. The right graph discusses hysteresis, and that's something we already spoke about, right? It's the same kind of thing. On the top, this is also really important just to be able to read this graph, because you do need to be able to reproduce this for yourself on your test if you ever get a question about this stuff. And of course, you're going to have questions on respiratory, right? So FRC is critical. We can already tell it's one of the most important points so far. That is the point where you just finished normal expiration, right? So all you have in your lungs is the expiratory reserve volume that you can forcefully breathe out, and your residual volume, which always stays in there. Alveolar pressure is at a minimum halfway through inspiration, right? And that's the point we're talking about right here. Halfway through inspiration, alveolar pressure is the minimum, and that's like a -2. While it is at a maximum halfway through expiration, right? When you're expiring air, it's at a maximum up here to almost +2. Breathing air in makes alveolar pressure negative, while breathing out makes it positive, right? You can see that. That's why it's going down here and it's going up there. Intrapleural pressure is at a more negative minimum at the end of normal inspiration, right? And that's this intrapleural pressure. Normal inspiration goes all the way to the middle point up here. When you finish normal inspiration, your intrapleural pressure is at a minimum, almost -10, right? These are all different points you can get questions on. And that would be your tidal volume right there, right? Which would be your tidal volume, VT. When intrapleural pressure is at a minimum, alveolar pressure is 0, right? And that's another thing you can see in this graph. The reason things happened at the halfway point for the alveoli is because at that point, most of your breathing, or the rate of air income, was done, and then it slowed down. Right? So what's happening? Basically, if there was a y-axis here for something else also, then it would be time, right? Time would be on this axis over here as well. And what that would show you is that all of this occurs in very, very quick time, right? You breathe in and you breathe out. Each one of those things doesn't take any more than half a second. So you can essentially say that this entire thing occurs in a second, right? One whole circle of breathing in and breathing out. And essentially, you know it's a circle, right? Everything is often in math described as a sine curve or a cosine curve for a reason. Is because if you were to actually shift this over to here, right, this curve, then you would make a circle. You would have a circle if you shifted this over, right? Breathing is a very cyclical thing that you do. And what this is showing you is if this occurs in 1 second, right, then there's a rate of breathing, right? When you first start breathing, when you have nothing in your lungs and then you first start breathing, by the halfway point here, you've gotten majority of the breathing in, right? Because breathing is quick. For normal lungs that have normal anatomy and everything, in the beginning half of it, majority of the air came in already. The latter half, it was just you filling up the amount of air you can possibly take in after that. So up to here, up to the halfway point, the rate of breathing was really, really quick. So alveolar pressure becomes negative, then starts coming back to normal, right? Breathing in, though, does force your alveolar pressure to be more negative, and then it starts normalizing again. And breathing out, which also in the first half of a second, you're done breathing out majority of the air. Breathing out is at a higher rate in the first few seconds, the first few microseconds, right? Portions of a second. And then it normalizes again. But your alveoli are able to stay normal most of the time. They're supposed to and they need to thanks to surfactant. And because if they don't do it, then they're just going to collapse and you'll die. You won't be able to do gas exchange anymore. Be able to reproduce this graph without looking at it, and then be also able to describe and explain everything that's happening in it without really needing to read this again, right? But the good thing about these videos is that you can go ahead and rewatch it again, go back to a couple minutes ago and listen to it again, or just pause it and keep reading it again. And the point is, you need to make sure you are able to grasp it, right? Not just memorize it. There's not really much to memorize at all. You need to master it. Make sure you know what's happening, and then continue to kick ass with that, because this is something that if you remember, if you have it drawn in front of you, it's kind of like having first aid in front of you, and you can just go kick ass and you won't have to worry about anything, right? And keep in mind the minimal mathematic concepts I'm mentioning here, knowing that compliance is a slope here, knowing that compliance is very important everywhere and is calculated with changes in volume and pressure, right? And that this is also inversely proportional to wall stiffness, if that's what you have to get a question on, right? The same kind of things were also important in the heart. The wall stiffness of the heart was important. Whether or not your heart was too stiff was important. Whether or not it was compliant was important. Same kind of things are often going to be compared to each other over and over. Thank you so much, Milton. You're the best, man. You've always been there to support me. And Happy New Year. Happy New Year, Milton. Right, so that's lung and chest wall, right? And this graph is not that bad at all. Just make sure you understand that the main thing you're seeing here are the two curves. This blue one here that goes like this, and the red one that's here that goes like this. That's really all you're worried about, nothing else. And the two are going in opposite directions away from each other because they are compliant. If they were not compliant, then they would all collapse, and the lung chest wall net system would have nothing to hold it up, and your lungs would just explode, and then you would die. Right, so that's basically all this is showing you. You almost never really get a question on this, though. Most questions are going to be regarding the lung volume, alveolar pressure, and intra-alveolar pressure. The other half of this page talks about other big topics: respiratory system changes in the elderly, and then, of course, hemoglobin, something that was discussed a lot in Hem-Onc with blood and stuff, but not revisited in a respiratory manner. Over there in hematology and oncology, they talked about hemoglobin a lot in terms of structure and function, and then how it can get messed up in sickle cell and other anemic diseases. Here they talk about its function as an oxygen carrier, as well as the guy that helps you have your energy. So respiratory changes in the elderly is something that's really easy to memorize by a couple things. Just make sure you do know it, though, and then we'll take a look at this graph. So basically, aging is associated with a progressive decrease in lung function, right? Aging is associated with a progressive decrease in almost everything's function. TLC, however, your total lung capacity in normal aging, remains the same. Your total lung capacity should not change. You might have more dead space. That doesn't mean that the total lung capacity changed though, right? Just because you have dead space doesn't mean that you have lesser air in your lungs. Dead space basically means that there's no air gas exchange there, right? So you can still have air in your lungs that isn't going into gas exchange. Now, what are things that increase with aging and what are things that decrease? Things that increase with aging are lung compliance. There's a loss of elastic recoil, residual volume, VQ mismatch, and the AA gradient. All of these are things that increase with aging. Now, if you lose your elastic recoil, right, your lung compliance is going to increase, which means that your lung isn't really going back to normal size. It's just stretching out more and more and more, and that's not so good. In fact, if it is stretching out more and more, it just means that you're increasing your residual volume because there's more air that's coming in that just gets stuck in there. You're also increasing your VQ mismatch because you have more ventilation, but not all of it is perfusing, right? Which means that you have more air coming in, but not all of it is participating in gas exchange. And same kind of thing with AA gradient. It's just bigger, right? And you can see how all of these are pretty much two-letter or two-word things, right? And that's what I'm writing down here. So all the things that are increasing are 2 letters or words, and the things that are decreasing are 3. So let's look at all the things that are decreasing. Chest wall compliance, right? This is 3 words. Chest wall compliance is decreasing because your chest wall, your actual musculoskeletal system becomes more stiff, right? And that's normal. That's something we all know about ourselves. FVC and FEV1 both decrease, right? Your functional vital capacity and your forced expiration of air in 1 second, amount of air you can breathe out in 1 second, all decreases. Respiratory muscle strength, again, another thing that's 3 words and musculoskeletal related, we know about it. It decreases, right? Your respiratory muscle strength is not going to be so good anymore. In fact, all your muscles are not going to be so good depending on what age you are. And then ventilatory response to hypoxia or hypercapnia, right? Any kind of issue with hypoxia where you don't have enough oxygen, or hypercapnia where you have too much CO2, those things are harder to fix in elderly people, right? So how does this look graphically? So UWorld had a really nice image given with a question, which was this one. So let's take a look. Compared to midlife, what changes are most likely expected as a result of normal aging in any patient? And the correct answer was TLC unchanged, FVC decreases, and residual volume increases. TLC is 3 letters, but you have to remember TLC is the one thing that does not change. And you can see that in this graph. You can visually now appreciate what's happening. Total lung capacity is everything from here all the way up there, right? That's your entire lungs capacity. That doesn't change. Your lung doesn't suddenly have the ability to have more amounts of air in it. Generally speaking, a healthy lung will just have a little bit of change in compliance, but it's still going to have the same total lung capacity. Vital capacity, you could see vital capacity is the amount of air that's actually being used when you're breathing in and breathing out, right? Vitality. And that, you can see this slope is showing you what's happening, right? Your vital capacity is pretty good up to age 35, not so good when you reach up here, 65 and above. We care about 65. That's the cutoff point for someone that's concerned legally elderly, right? Any question you ever get where a patient is 65 or above, 60 or above, you really want to start thinking of things that occur with elderly people, right? And the Beers criteria of medications you can give to elderly people, the fact that BPH is a bigger thing for elderly males, right? Breast cancer is a thing for elderly females. These are all the things that should come to your mind. So vital capacity, the 2-letter thing, is going to decrease, right? Not so good anymore. Right, and that's the only thing you got to be careful with, because most of your 2-letter things are increasing here, but you see they don't put vital capacity on this list anywhere, right? They have FVC, which decreases. So just think of vital capacity with that FVC. FVC decreases, right? Functional vital capacity is the way you can think of it as. So I summarized it over here, right? TLC stays the same. FVC, IRV, and ERV are all things that decrease. The amount of air you're actually working with for breathing purposes decreases, right? And then things that increase are your residual volume by a lot. It was about 1 in the beginning. It almost triples, Right? So that means you have a lot of shit air in your lungs that you're not really using for respiratory purposes. And FEV1 and the diffusing capacity decrease. That's another thing you have to keep in mind, the diffusing capacity, which is often written as DLC0. The diffusing capacity of carbon monoxide, basically, not zero, CO, DLCO, because you're not going to have that many functional alveoli by the time you're that much older. So you get silly questions, and you have to be ready with the answer choices. Make sure you look at all your answer choices and cancel out any answer choice that has even one thing that doesn't really make sense, right? Here, this was the correct answer choice, and then they gave this image, and they had no whole explanation of what's happening. All right, so let's take a look. Aging is associated with a number of changes in pulmonary function. Patients aged 35 or above experience a steady decrease in chest wall compliance as a result of stiffening from rib calcification and from increased thoracic curvature due to osteoporosis and osteoarthritis, things that occur to elderly people. In contrast, lung compliance increases with age due to a loss of elastic recoil, particularly in the alveolar ducts. The dilation of alveolar ducts is homogeneous and as opposed to the emphysema associated with COPD, and is not associated with destruction of alveolar walls. Diminished elastic recoil and the collapse of supporting tissues around the airways cause significant increase in residual volume. However, TLC remains unchanged because the decreased chest wall compliance counterbalances the increased lung compliance. In addition, as residual volume becomes a much higher proportion of TLC due to air trapping, FVC also decreases. Right? And those are the two big ones you want to remember: vital capacity and residual volume. They're pretty much working in opposition with each other, right? Vital capacity does not use residual volume. So if you have more residual volume, you're basically taking air away at the vital capacity because you don't use residual volume for breathing per se. It's not something that you inspire and expire. It's just sitting there. It's air that's sitting there in the lungs, never moves around for the most part. Other age-associated changes include decreases in FEV1 and the diffusing capacity of carbon monoxide. Right, so that's basically the whole concept of respiratory system changes in the elderly. The next thing is hemoglobin, and here there's a whole conversation about taut versus relaxed, and oxygen affinity, and the whole function of 2,3-BPG, which is very critical, and you should be a complete pro at it before you sit down for step 1. 2,3-BPG can be pretty intimidating and confusing for a lot of people also. So don't be worried, and make sure you just study enough to truly have a complete understanding of what the hell 2,3-BPG is even doing. They tell you hemoglobin is composed of 4 polypeptide subunits, 2 alpha and 2 beta, and they exist in 2 forms. Either deoxygenated, which has low affinity for oxygen, thus promoting release of or unloading of oxygen, and the oxygenated form, which has a high affinity for oxygen and exhibits positive cooperativity and negative allostery, which are 2 more concepts you have to know about. High chloride, H+, CO2, O23-BPG, and high temperature favor the deoxygenated form over the oxygenated form, and it shifts the dissociation curve to the right, causing more oxygen unloading. Right, so when things are high, you have oxygen unloading. And that's something that we're going to really need to spend a lot of time on when we get there, right? So eventually we're going to get to the oxygen hemoglobin dissociation curves. And this is where we're going to truly understand what's happening with each of these factors that they just mentioned, right? H+, which is just acidity. PCO2 is also related to acidity. 2,3-BPG, temperature, carbon monoxide, right? Altitude, all of these different things. What do they do to the oxygen hemoglobin dissociation curve? Most of it is actually, believe it or not, common sense. But because it's worded, right, even though you know it, you might not know how to word it. And that's where it can become a more confounding factor. They then go on to tell you that fetal hemoglobin, which has 2 alpha and 2 gamma subunits, has a higher affinity for oxygen than the adult hemoglobin, driving diffusion of oxygen across the placenta from the mother to the fetus, right? So the fetus is able to steal oxygen from the mother because fetal hemoglobin has more affinity for oxygen than our own adult hemoglobin. High oxygen affinity results from a decreased affinity of fetal hemoglobin for 2,3-BPG. Right? So basically what this is telling you is that 2,3-BPG is a bad guy. If you have a lot of 2,3-BPG, your affinity for oxygen is going to decrease, and then you're going to let go of oxygen. where would you find 2,3-bisphosphoglycerate? Where would you find this? Well, it's mostly going to be in muscles that are using up glycolysis a lot, right? 2,3-BPG, believe it or not, actually came from biochemistry metabolism, where you were doing glycolysis. And if you're doing a lot of glycolysis, that means you must be trying to make a lot of energy to work out or exercise or something like that, right? So if you're doing exercise, you need to have a low affinity of oxygen in that area so that you can unload the oxygen, right? That totally makes sense. So if we're talking about in our muscles, right? If I'm lifting, if I'm running, whatever I'm doing, when the hemoglobin reaches my muscle and sees a lot of 2,3-BPG, that hemoglobin will immediately know that this area needs oxygen. And that 2,3-BPG is going to decrease the affinity of this hemoglobin for the oxygen it's holding. So it can let go of oxygen and give it to the muscle. Right? And that's a very important thing to remember. So always think of 2,3-BPG as the guy that tells hemoglobin to let go of the oxygen. Right? You won't have a lot of 2,3-BPG in your respiratory system. You're not going to have a shit ton of 2,3-BPG in your alveoli, because here in our chest, in our lungs, hemoglobin needs to have a high affinity for oxygen. This is where it picks up oxygen. Right? So that's why all of the hemoglobin that is in our lungs is going to be the one that's oxygenated. Right? The oxygenated form. It has a high affinity for oxygen. It's going to pick up oxygen, and then it's going to go back into the circulatory system. All the hemoglobin that's in our muscles and everywhere else outside of the lungs, in our brain, everywhere, that is going to be deoxygenated hemoglobin. That's the one that's going to release the oxygen because it's done doing its job as a carrier, right? And there are other words. They're taut and relaxed, and those are also forms you have to know about. They furthermore tell you hemoglobin acts as a buffer for H plus ions, right? So acid, basically. If you have a lot of H plus, hemoglobin will be there to buffer that. Myoglobin, which is a special type of hemoglobin, is composed of a single polypeptide associated with one heme moiety. It has a higher affinity for oxygen than normal hemoglobin, right? And that's very important because your muscles definitely should be able to grab oxygen very well. You don't want to be weak somewhere. And then as far as the vocabulary of taut versus relaxed, so taut means low oxygen affinity, and you know low oxygen affinity means deoxygenated, right? Taut is the one that delivers oxygen to muscle. The relaxed form has high oxygen affinity, and you know high oxygen affinity is oxygenated, right? So taut is deoxygenated, relaxed is oxygenated. You can relax when you have oxygen. So relaxed is the one that's in the lungs, right? And that's just something that I used for memorizing that. And this is just basics right now. This is just straight basics right now. Because later on we're going to see the dissociation curve where all of this has to make a lot of sense. And then if you also do a quick revisit of Hem-Onc, which today would be a good time to do that, then right here in my first video of Hem-Onc embryology, I talked about it, right? 2,3-BPG, how the hemoglobin actually looks like, how it works with 2,3-BPG and what the interactions are. All of that was discussed in Hem-Onc, right? And then in respiratory, we're going to see how that hemoglobin is affected by exercise. Let's see what's said. I also imagine the muscles are area which is high in temperature and the acidity because of the amount of work it does, so it makes sense that increased 2,3-BPG, age, and temperature go together. Definitely, yeah, right? That's another great way to memorize, right? Most muscles that are working out are going to have lactic acid release, a lot of lactate, which is also really related to stuff we saw in metabolism. Pyruvate being shunted to lactate, don't forget that, right? That's stuff that's happening in active muscles. So active muscle has high temperature, high acidity, and high amounts of 2,3-BPG, and all of that is paired together. So the reason that is important to remember together, and Syed brings up a great point, is because that is going to go together in this chart. Right? In this chart, all of that is going to go together. So if you have high H+, exercise, high 2,3-BPG, high temperature, right? All of these are things that cause the right shift, and the right shift basically has more oxygen unloading, decreased affinity for oxygen. You let go of the oxygen, and that stuff is stuff that occurs in, you can see arterial blood, right shift, right? Arterial blood and blood that's in the muscles, Right? Blood returning from tissues is venous blood. That's the blood that has a high affinity for oxygen. It wants new oxygen now because it's empty. It needs new oxygen, and then it's going to go circulate again. So very, very nice way to remember that too. And when we get to this point, I'm going to talk about each factor in more accuracy to make sure it makes more sense. It's not a memorization thing. You do not want to spend time memorizing that stuff. Okay, so that's basically all of that. Let's take a look at some of these other questions I have here. So there's another UWorld question down here related to some stuff we've already seen in previous videos in respiratory embryology. So it says respiratory physiologists conduct a small volunteer study to assess airway resistance within the lower respiratory tract. During the experiment, they measured the local contribution to total airflow resistance at different points along the bronchial tree. What curve best corresponds to the airway resistance pattern seen in normal lungs? Right, and then the image to the left was the answer. The upper respiratory tract, nasal passages, mouth, pharynx, larynx, all account for half of the total airway resistance. The remainder derives from the lower respiratory tract, which begins at the trachea and consists of about 23 generations of airways from the trachea all the way to terminal bronchioles and alveolar sacs. Although resistance in the trachea and mainstem bronchi is relatively high, it increases in the medium-sized bronchi because of highly turbulent airflow. Resistance is maximal between lobar bronchi to subsegmental bronchi. You have to remember that. But drops afterwards because the summated cross-sectional area massively increases. This greatly slows airflow velocity, allowing low-resistance laminar airflow to predominate in airways that are really, really small, less than 2 millimeters in diameter. Right, so you can see resistance is super high right here in medium-sized bronchi. From there, right, as this starts dividing into more and more areas, those divisions decrease resistance. And this is something we talked about a little bit earlier a while ago when we were in respiratory physiology as well. Sorry, respiratory embryology as well. So make sure you remember this, right? Maximal right here, while it's still one tube, this one tube has a lot of airway resistance. Why? So I described this in about 2 videos ago. I described this as a fork in the road. If let's say there's 100 people walking on this one road, if all of us are walking together in this direction, we're all going to keep crashing into each other, right? By this time, we divide half and half. 50 of us go this way, 50 of us go this way. Although the road gets smaller too, there are fewer people to crash into each other, okay? And then up to here, maybe 25 of us go this way, the other 25 go this way, and we all keep splitting up. Eventually, it's going to be one person on one road. Pressure is 0. Right? So think of it like that. 100 people on one big road or one person on one very small road. Where is the pressure higher? The pressure is obviously going to be much higher with 100 people in one really big road. We're all going to crash into each other if we're running a marathon. But one person running on one very, very, very thin road at the end over here is going to have no pressure. There's no one he's going to crash into. There's nothing he has to worry about. He can keep running. Even though it's a thin road, he doesn't need more space. He's just one person. Okay? So really a simple way to memorize that would just be that analogy I just made right now, and keep this graph in your mind. Right? Nothing crazy is happening here, but it's very important to remember, because if you don't know this conceptual way of thinking about this, then if you get a question asking you where the pressures are high and where the pressures are low on this entire bronchial tree, it's not really something that you can derive from just thinking, unless you have that like Albert Einstein level physics understanding and you can just think about it and derive it. That's a whole different thing, and I'm sure some people do have that, but generally it's easier if you just remember this, right, and this analogy and this conceptuality. Another question, this one right here, is 66-year-old man hospitalized 3 days ago for left lower lobe pneumonia, is evaluated for persistent fever. He has been receiving the appropriate IV antibiotics as determined by antibiotic susceptibility testing of his sputum cultures. He has a history of diabetes and hypertension. Temperature is high. Pulse is 87, which is also fast. Exam shows dullness of percussion and decreased breath sounds over the left lower lung. So later on, when we get through more of respiratory physiology, we're going to understand what it means when you have dullness to percussion, right? If you have dullness to percussion, it generally means there's fluid there, all right? That's why it's not percussing. Percussion would not really be dull if there was just air. That would actually be working just fine. Dullness to percussion tells you there's actually fluid in that area. So a tube is placed to drain the fluid via an incision at the fifth intercostal space in the mid-axillary line. Right, and this is just revision of some things we've looked at in previous videos just a couple days ago. What muscle is most likely to be dissected during the procedure? So they took a respiratory question and completely switched gears to talk about anatomy, right? Musculoskeletal. So chest tube placement does often break through these muscles, and it's very important to know that. This is the image that shows you that. Right? You can see the anatomy here. Along this mid-axillary line, you have a bunch of your anterior serratus muscles, right? Or serratus anterior muscles. All of these guys. These guys are all here. Your latissimus dorsi is coming from the back, and then of course you have your chest pecs, right? Pectoralis major. The anterior serratus muscles are the ones that are going to be pretty much pierced to do a mid-axillary chest tube placement, right? And that was the answer here, serratus anterior. Image below is in the explanation. This patient most likely has empyema requiring drainage with a chest tube. The tube traverses the serratus anterior muscle, intercostal muscles, and parietal pleura to reach the pleural cavity. Recall from anatomy, the serratus anterior originates as multiple branches from the side of the chest along the 1st to 8th ribs and inserts along the entire length of the medial scapular border all the way to the back. It has 3 parts, the superior, intermediate, and inferior, depending on the insertion site at the scapula. The inferior part facilitates arm elevation by pulling the scapula forward, and all 3 parts help with respiration by lifting the ribs. Innervation is via the long thoracic nerve, which actually travels like this line, right? The long thoracic nerve. And we saw that when we looked at the brachial plexus. So a little bit of musculoskeletal revision, and then the most intimidating question for today is this one. Directly related to some of the shit that we just talked about right now. So if you ever get curves like this one, where they're showing you 2 lines and they don't show you the total, they almost never show you the total, right? When they show you 2 lines like this and they maybe show you the total, you need to understand that this is basically the same stuff we were looking at much earlier today and in the video right before this. So this question says, a 53-year-old patient presents to your office with the chief complaint of dyspnea. 2 graphs are presented below, with the minute ventilation being constant and equal in both graphs. The right-sided graph shows how the work of breathing varies with respiratory rate in this patient with dyspnea. The graph on the left represents the work of breathing versus respiratory rate in a normal patient. The image given is the normal and increased elastic resistance, right? So these are the 2 they're giving. They're giving increased elastic resistance and normal in the question. This entire thing is given in the explanation, but in the question itself, they only showed you these 2. But they are not labeled, and there is no blue line, right? So this blue line is not shown. This showing you where the respiratory frequency is at for lowest point in the total is not shown, okay? The image to the right is given in the explanation, which is this entire thing up here. What is the most likely diagnosis? So if you ever get a graph like this one in the middle, right, or if you get a graph like this one over here, you need to be able to figure out what's wrong with the person just by looking at the graph, right? And this is normal. So what's happening in normal? Well, basically, airflow is on the y-axis, work of breathing is on the x-axis. Work of breathing you can also think of as synonymous to pressure, right? Because the more pressure, the more work you need to breathe, harder to breathe. So as you're breathing this way, you can see how the total pressure first decreases, then increases. This is the same exact thing we had way in the beginning right here in this graph. Right? As you're breathing in, total pressure first decreases, then increases. That's your alveolar pressure, basically. So if we come back to this graph right now, and we remember that graph, we understand that this makes sense. It should be decreasing, then increasing. And this point, with the minimum point, is the point which is FRC. And this is where we need to see how much is breathing rate, right? Respiratory frequency, breaths per minute, 15. 15 is about normal. So 15 breaths per minute, and this is how the graph looks. For this patient, it's more than 15, right? And they told you this is normal. They gave you this one also. So you know that now the minimum, first of all, the minimum is much higher. It's at a higher point, right? And both of these graphs, the elastic and the airflow, are now a little higher up. And you can see that this minimum point shifted to the right, closer to 20. So respiratory frequency is higher. What does that tell you? It tells you that most likely this patient, from the list of answer choices they gave you, only one of them would fit this. It was pulmonary fibrosis. The work done against the elastic resistance of the lung is increased when the tidal volume is increased, while the work done against airflow resistance is increased when the breathing frequency is increased. Those are the two different kinds of case scenarios you can get, right? Our guy is the second one. Work done against airflow resistance is increased when the breathing frequency is higher, right? Here the breathing frequency is higher. That means that he's having to work more because of resistance in the airway, which is related to pulmonary fibrosis. If there's fibrosis in the alveolar areas, that's resistance in the alveolar pressure places, and you have to breathe more often to get more air there. If the two components are summated and the total work is plotted against respiratory frequency, there will be an optimal breathing rate at which the total work of breathing is minimalized. For the normal adult, the rate is on average 15 breaths per minute. For patients with stiff lungs, the work of breathing is minimized when the respiratory rate is high and the tidal volume is low. Therefore, rapid and shallow breathing are favored in diseases that increase elastic resistance, and any of these would have been correct answer choices. Pulmonary fibrosis, pulmonary edema, respiratory distress syndrome, any of those. In contrast, diseases that cause high airflow resistance, which is over here, right? You can see how the airflow one is significantly higher, right? We're comparing airflow. Airflow in these two guys is pretty much the same, right? What's different in these two guys is the elastic one, right? Much higher. So if you can't see it, let's just say like this difference, right? This difference is higher, right? Entirely. The elastic recoil went up much more. The airflow curve stayed about the same between these two graphs. But if you compare the first and third one, airflow, right, went significantly higher here, right? Much higher. So airflow resistance is higher. If airflow resistance is higher, remember airflow is your nose, your trachea, all of that. So if airflow resistance is high, that means you're having trouble bringing air in. And if you have trouble bringing air in, naturally your respiratory frequency decreases, right? Less than 15. If you have trouble with your elasticity, which is this line, that's inside your lung, right? Elasticity. That means that you're just going to have to breathe more often to get more air in there. But you can breathe fine. And that's how I memorized it. And those cases where you have trouble with elasticity are going to be things like asthma, COPD, right? Where patients breathe at a lower rate and they take slow, deep breaths in order to minimize the work of breathing. Now, another case scenario where stuff like this happens is also high altitudes. Earlier last year, in August, I was in Colorado for the Tough Mudder, and Colorado is at a very high altitude. So even when I was taking little jogs around with the dogs at the friend's house that I was at, I would get exhausted, run out of air immediately. The only way to fix that with the high altitudes, the only way to fix that for me was to take slow, deep breaths. And then I would have energy throughout my exercise, throughout my jogging, running, and of course the Tough Mudder. So these are things that you have to know. Because you get silly questions where the correct answer is going to be either doing rapid shallow breaths or slow deep breaths. Okay? And where do you do it? Why do you do it? So make sure you spend a little bit of time really grasping the concepts that all three of these graphs are telling you and what's happening in this question's explanation. Right? If you have increased airflow resistance, you cannot breathe anyway. It's like your nose is kind of clogged, right? So you can't really breathe much anyway. So you do slow, deep breaths. You breathe slowly, but you make sure you breathe really, really deep. Why can you breathe deep? Because the elasticity is working fine. You can see this elastic curve is the same as it is in the normal. So you could breathe in just fine, but not quick enough, right? Because the air flow path from your nose all the way to your trachea is not working too well, as in asthma, where your trachea can actually constrict in a sense, right? And if you're here in this case scenario where the elastic pressures are high, you don't have elasticity. In these cases, airflow is, that path is fine. So you could breathe in more often, but you can't breathe deep because your lung is fucked up, right? So make up whatever you have to, whatever scenario, whatever explanation works best for you. Make sure you understand this stuff because you will have a question regarding these kinds of things. You will have a question on all of these diseases on your step one. So you got to make sure you know everything about these pathways, these pressure differences. These are basically the most complicated things you can get questions on regarding respiratory. The easier things to get questions on are direct questions about pulmonary fibrosis, respiratory distress syndrome. Those direct questions about pathology are easy questions. pathophysiology of how those diseases work with your lungs physio is in second level higher difficulty question, and that's the one that you don't want to mess up. Those are ones you will really want to study hard for. If you can understand this, you'll understand the general pathology a lot easier. Alright, so we'll stop here. In the next video, we'll do a little more revision of changes in thoracic volume before moving on to cyanide versus carbon monoxide poisoning. Thank you very much for joining. I'll see you guys again very soon, and thank you once again, Milton. I really appreciate the support.